Okay, so hello everyone, and apologies for my late arrival. I'm Beth Lawton and I am the Chief Digital and Information Officer for Sussex Partnership. And so it was my team that led our digital response to COVID-19. So before we start, I thought it might be useful to talk about what I mean by digital, because well, I mean, you can get 10 people in a room and have 11 definitions of digital come out of it, and that's just amongst the types. So for the purposes of my conversation, I'm talking about digital being the way that we use digital technology. Now that's hardware, that's software, and the data that sits on it to deliver services in new and or improved ways. So from our perspective within Sussex Partnership, we had 5 things that we felt we really needed to do as quickly as possible when COVID hit us. First was to mobilise our workforce. We obviously have a lot of people. We've got over 6,000 staff within Sussex Partnership. We wanted to keep them as safe as possible while still maintaining a safe level of services for all our service users. So key to doing that was to make sure that as many people as possible could work from COVID secure areas. Now, for a lot of people, that meant working from home, but also it meant perhaps changing the clinical settings, so people wouldn't be working in the areas that they normally worked in. So we had one piece of work, which was to get our workforce as safe as we could while still being able to work as effectively as they could. We also stood up a 24/7 mental health line. So the hardware and software behind that to make sure that people could staff that phone line from the comfort of their own homes, that we had all the phone infrastructure in place so we could divert calls amongst people, both on site and off site. And of course, that we could make sure that they had access to all the appropriate systems that they needed in order to both be able to give appropriate advice, to refer people where appropriate, and also to access things like clinical records where necessary to get background information. We also thought that it was really important to maintain our Discovery College, which many people may know is a peer support learning facility, which is incredibly useful to our service users. And so, although that's mainly done in person in the pre-COVID times, we wanted to make sure that was still maintained as a resource. So we put that together online, moved all our courses online. And then we looked at which of our services could be virtualized. So where could we move them away from face-to-face and into the digital arena? And obviously we deliver many services. It's not just one-to-one consultation. There's the learning, there is group sessions, there are workshops, and there's been the behind the scenes work away from clinical settings as well. And key amongst all of that was our virtual consultation. So pre-COVID, we had a small number of teams who were offering a very small number of virtual consultations. So we had the software in place, we had the policies and procedures, but actually adoption was thin on the ground and quite patchy across the trust. What we wanted to be able to do, we set ourselves this as a goal right at the beginning of COVID, was we wanted to be able to make sure that every clinician should be able to offer a virtual consultation and every service user or carer should be able to request one. And we wanted to do that right away across the board and across all our services. So we started off just using Attend Anywhere. We spun it up very quickly. There was a national offer and we started using that for all consultations, both with service users and or their carers. We already had Skype within the trust for professional meetings. And very quickly, we realised that the combination of the two wasn't enough, simply because of the different interactions that we have with people. So we brought in a number of other products, GoToMeeting for group interventions, because obviously we have quite a rich pattern of group intervention and workshops that are happen across the trust, and also Zoom, which we're now using Zoom Enterprise under pilot because of the functionality of things like breakout spaces, which weren't available within Attend Anywhere. And we've also tried to take a really flexible approach to using other apps where those solutions didn't fit what was needed on a clinical ground. So we've been guided by the clinical need and the service user preference, but also trying to make sure that in all of these, we're making sure that all the appropriate information governance and other security protocols are in place, because that is incredibly important to us. And so where we've used something novel, so for example, our dysphagia clinic, that's for people who are having trouble swallowing. Obviously, you can't assess if somebody's having trouble swallowing in the middle of a Zoom call. So we use WhatsApp, so a carer can actually film somebody swallowing, so we can see the issues there from a remote session rather than having to have people come into a room together. If I look now in terms of Attend Anywhere, we had a rapid take-up and a fairly consistent take-up across the trust. Now, this is our cumulative numbers, and so I won't get too blown away by the actual numbers that we've run over the year, although that's way up over 55,000. But I think more to show here that it is a fairly level line showing that the use of Attend Anywhere has been consistent across that period from March to November. And also to flag our mild smugness at being the highest adopter of Attend Anywhere right the way across the NHS England. If we look at how those numbers actually break down, and apologies, this is a fairly small slide, but just to show the top bars here are showing the highest numbers of consultations, and the services that are primarily carrying out those video consultations are our primary care, so Health in Mind, Brighton and Hove Wellbeing Service, the partnership that we have with the YMCA, and then we're moving into CAMS, so Children and Young Adult Services are the next highest adopters. And I suppose some would say that isn't that inevitable because younger people are more likely to be digital adopters, but we didn't find that was necessarily the case. But throughout this, we've been really keen to not just throw technology to the problem and see whether it sticks. We wanted to make sure that we had some feedback, some fact-based analysis, so we could tell what was working, what wasn't working, and how we could then have a learning process so that we could see what we would transition into our day-to-day practices when we moved on into the post-COVID world. So we started off by having a very short survey sent to both our service users and the clinicians at the end of a virtual consultation setting. And this gave us some interesting information. So for a start, so I'm not going to go down into the small print here, but just concentrating here on the right-hand side of the screen. This is service user and carer experience, and you can see that on the whole, the majority of the experience has been green, which is agree for pale green, and strongly agree is the darker green. So service users were reporting that they had the appropriate equipment and space to be able to use a virtual appointment. Now, I think I must caution, as Leicester did, these were obviously the people having virtual appointments, so you would expect there to be a high bias there. But importantly, people felt that they were able to express their experiences, thoughts and feelings during the appointment. They felt they're being listened to and understood, and the clinician and service user reached the outcomes that they had intended to. I think just keep in mind that level of greenness there, and we'll look at the corresponding clinician survey, and you'll see, although still predominantly red for similar questions, we do have more on the neither agree or disagree, disagree or strongly disagree. Part of that was on the reliability of the software for the session, the ability to assess risk, engage with the service user, and to reach outcomes. So on the whole, we're finding that service users are reporting a more favourable experience than our clinicians. And so for us, that was incredibly helpful and is helping us to shape our service the way we go forward. We've backed all of this up with more formal research done with partners at the University of Sussex to make sure that we're really gathering what the experience has been like overall, and also what we can learn from going forward. And so in terms of learning from our experience, I think first of all, a key thing is that we need to be thinking about flexibility in use of virtual consultation. And whether it's used or not should very much be a dialogue and a decision made jointly between the service user and the clinician. What we've really definitely found is there is no blanket use virtual consultation for this category of interaction and not for that category of interaction. It is very much to be guided by the service user in conversation with the clinician. I think a second thing that we have been acutely conscious of throughout this period is the whole issue of digital exclusion. We do find that there is a strong correlation between members of our service user population and people who are tending to be digitally excluded. And so I think when we first started, we blithely said, okay, well, we'll put this in place. Anyone can take part as long as they've got a mobile phone. We found that that perhaps, while not being untrue, wasn't really an accurate reflection of the situation. And going forward, we know that we need to do a lot more work in terms of digital inclusion. And we're now adding that to our digital strategy for the future. We also had to think about the impact on our clinicians. For many of those who are used to working in a clinic setting where there is professional support around them, if they need a friendly ear to bounce ideas off or discuss problems, we were expecting people who were working remotely from their own home without that support structure. And some people were struggling, your home is your safe space, and some people were having very challenging conversations without the backup of the support that they would have had at the office. So we learned quite early on that we really need to think about how we can support our clinicians more effectively, not just in terms of using the technology, but also that broader issue of well-being, professional support, and ensuring people were able to switch off within the home setting when they'd finished working. And then finally, in terms of learning from experience, I think, again, when we started, we were thinking about virtual consultation being a one-to-one thing, and that's where we focused our efforts at the beginning of COVID. What we've learned over the COVID period is how important group interventions also are to the therapeutic pathway that our service users are on. And so we have definitely realised how integral they are to the clinical offer and come to the recognition that multiple solutions are needed. There is no one size fits all. And in developing solutions from a digital perspective, then we have to think about how we make sure that our clinicians have a full box of tools that they can use and that they're feeling happy and confident in using those. But also that they have the skills to determine which is the best tool to be using, and that we then have the appropriate conversations with the service users as well to make sure that they're happy with the technology and with the approach that's being taken. So in terms of what's next, well, we're very much seeing this as the start of a journey. We've had some amazing successes. We've had some things which haven't worked so well, and we think right the way across the trust we are trying to learn from the experience of COVID as a whole, and the digital element is forming an incredibly important part of that. So we're already looking at what our services will look like in the new normal, and there are a number of work streams going in place as part of the wider ICS our sort of system offering there are conversations going on there about how we redesign our services to meet the world of the future. And digital is very much at the heart of those conversations. And we're looking at what a blended offer might look like. So where digital is best, where face-to-face is best, where your good old landline is best, and how we can design services to incorporate all those elements rather than being one or the other. We're looking across the wider health system and how we as a trust can feed into that based on our experience and the experience of our service users, and how we can start redesigning things at that level. So whether it is by giving people a what we call a patient portal, so people can actually access information about from their care record, take that with them whichever service they happen to interact with, so that we can get rid of that sort of every time you hit a boundary of a service, you have to give people the information again, which is both a waste of time, it leads to inaccuracies, and it's a bad experience for people. So we want to look at how we can eliminate that. And as I touched on earlier, we're also looking at how we can make digital inclusion part of our digital strategy, both within the trust and within the wider ICS structure, so that we don't leave people behind or people feeling that they're having a second-rate experience. You know, we're all very clear that digital interventions, digital consulting is never, ever going to 100% replace the physical face-to-face meetings. We don't want that to happen. But we want people to have a choice. And at the moment with COVID, we're perhaps skewing too far on our emphasis towards digital interventions, but we don't want to go back to 100% face-to-face following COVID. So we recognise that in order to make those options available to everyone, we've also got to think about digital inclusion. And so that will be part of our work going forward. So I think that's a whistle stop about what SPFT have been doing with digital over the COVID period. Obviously, it's a work in progress, and we are very much mindful that the pressure of COVID has made us make some quite quick decisions. We need to revisit those, and we need to